Hello, welcome to Ask the Expert session. My name is Dr. John Fahrenholz, and I'm an allergist immunologist in Nashville, Tennessee. I work at Vanderbilt University Medical Center. So in a recent program, Can You Compete? Best Practices for Non-Advanced Systemic Mastocytosis, we offered learners the opportunity to ask the experts clinical questions that came up while viewing the activity. Today, I'm going to be providing answers to some of those questions. There can be many triggers, and many are non-IgE mediated or not classical allergic reactions, and very common medicines that can trigger patients with mastocytosis include NSAIDs, such as ibuprofen, naproxen, Aleve, aspirin, and then other pain medications, particularly narcotic pain medications, are common triggers, and they trigger mast cells through a different mechanism. They trigger mast cells through the MRGPRX2 receptor. We've learned that quinolone antibiotics often will cause nonspecific mast cell activation as well, separate from an IgE-mediated process. Of course, radiocontrast dyes are another trigger, particularly the CT contrast. MRI scans with contrast, gadolinium, are usually well tolerated, as are scans of PET scans and the contrast agents used for PET scans. In some individuals, alcohol ingestion will be a trigger. Many patients, physical activity, particularly strenuous physical activity. And in general, as we think about patients with chronic urticaria, a lot of these same triggers hold true for patients with mastocytosis, and that would include physical triggers of rubbing of the skin, vibratory changes, also very hot weather or very cold weather, and in many people, change of weather from going from very hot to very cold will be a trigger for symptoms, particularly cutaneous symptoms with flushing, urticaria. Another big area is physical or emotional stress that can be a trigger, and strong emotional stressors are among the more common things that patients with mastocytosis will report as triggering symptoms. Another trigger is acute pain. So, of course, specific IgE-mediated triggers can be involved as well, and the particularly prominent IgE trigger would be venom allergy. So stinging insect, bee, wasp, yellow jacket, hornets. Those are known to cause very severe anaphylaxis in patients with mastocytosis. So that's a key trigger and a key trigger to know about in terms of when to think about the diagnosis, because patients who have very severe anaphylactic reactions to stinging insects should be screened with a serum tryptase, and you should be thinking about the possibility of mastocytosis in such a patient. Of course, other general allergens, such as food allergens, can trigger people with mastocytosis as they do people who do not have mastocytosis. And I think those are the big triggers to think about. So in terms of counseling patients around surgery, this is a time of increased risk, and we've already just touched on some of the triggers for mast cells and physical and emotional stress, certainly pain postoperatively, and also use of pain medications can be triggers. So the anesthesia and surgical teams need to be aware of the diagnosis. And of course, some anesthesiologists will be more comfortable than others. So it's important that the patient communicate with the surgical team and the anesthesia team ahead of time, and then involve us as the allergist immunologist to help coordinate the plan perioperatively. So a key thing is prior records. So if a patient has previously tolerated a surgery, and we can find records of what was used previously for induction, for pain control, that's very helpful for the patient and the anesthesiologist and the surgeon. So sometimes the answers are there already based on a prior surgery. In general, there are medications that are considered safer. The only narcotic pain medicine that doesn't trigger mast cells would be fentanyl. All the other narcotic pain medicines will trigger mast cells. That doesn't mean they're contraindicated, because many people will still tolerate them, but it's a caution. And so the medicines like morphine, hydrocodone, they will commonly cause at least cutaneous symptoms. Propofol, benzodiazepines are also generally very well tolerated. Ketamine, and then tramadol, not Toradol, but tramadol as a pain medication is also another med that is generally very well tolerated. The other point would be maintaining their typical anti-mediator medicines with histamine 1, histamine 2 blockers. And in some patients, and depending on the stress and the type of the surgery, another important point is to maintain a patient's anti-mediator medications with H1 and H2 blockers leading up to the surgery. And in some cases, thinking about pre-medications in the pre-op area with IV antihistamines and or systemic steroids in select patients. In my experience, that is usually not necessary, but again, considering all potential triggers and the individual patient is important. Okay, this is a very interesting question. The patient who comes into us with a mildly elevated serum tryptase, a history of cutaneous symptoms, and then another system involved. In this patient, it's abdominal cramping. And how do we evaluate this patient, and what should the approach be with our current testing availability in terms of looking for hereditary alpha tryptasemia or systemic mastocytosis? So in this patient, my approach will be to look for the hereditary alpha tryptasemia gene duplication, sending out that genetic test. And then as an excellent screen for systemic mastocytosis, I send the peripheral blood high sensitivity KIT D816V mutation. There are several laboratories that perform the high sensitivity test, and it's important that we do the high sensitivity test because it will detect the KIT mutation in peripheral blood down to about 0.3% variant allele frequency. The older tests are down to a detection rate somewhere around 10%. So that is not sufficient in trying to evaluate hereditary alpha tryptasemia versus systemic mastocytosis. Also important to think about is the fact that systemic mastocytosis and hereditary alpha tryptasemia can occur together. So they are not mutually exclusive. So if you have somebody in whom you have a high suspicion for mastocytosis, particularly if you find the KIT mutation, so a KIT mutation in peripheral blood and the hereditary alpha tryptasemia mutation, this is somebody who probably has both hereditary alpha tryptasemia and systemic mastocytosis. On the other hand, somebody who has the serum tryptase of 15, a negative peripheral blood mutation for KIT, and a positive finding for hereditary alpha tryptasemia, that's a patient that I don't believe you need to move on to a bone marrow biopsy in the vast majority of situations. There are patients who have 2 extra copies of the HAT gene, and they will often have levels of serum tryptase above the cutoff of 20 for the minor criteria for systemic mastocytosis. In those situations, generally, it's best to go ahead and move forward with a bone marrow biopsy. There could be some select situations where if you had the negative KIT mutation from peripheral blood and you knew the copy number of the hereditary alpha tryptasemia gene, you might watch and follow closely. But I think you're never wrong to make sure and proceed with a bone marrow biopsy. The other valuable information you have with a bone marrow biopsy is that it rules out an associated hematologic malignancy. So even in situations where you might not have an extremely high index of suspicion for mastocytosis, ruling out an associated hematologic malignancy is often an important piece. Okay, in terms of clinical trials, this is something where it really comes down to patient education, shared decision making. There are still active clinical trials looking at alternative treatments, tyrosine kinase inhibitors included, and the discussion really has to center around, is avapritinib appropriate, and does the patient want to move forward with avapritinib, or would they like to be involved in a clinical trial? Yes, so with avapritinib approval, I think we need to let people know that it is available. It wouldn't be a situation where somebody would fit a clinical trial but not fit avapritinib for the most part. Of course, some of the clinical trials are recruiting and available to patients who have already tried and failed avapritinib. So that would be an individual who we would be discussing a clinical trial. However, some people might be interested in participating in a clinical trial for other reasons, and they might choose to do so as opposed to beginning avapritinib, but that's a shared decision-making discussion that would go over all options, as we wouldn't want anybody to choose going into a clinical trial without knowing that avapritinib is FDA approved and available. All right. Thank you for your time today. I hope this information is helpful. As you can see, you can sign up for Exchange CME's YouTube channel and check back for updates. Thank you.